So this was my first test. I got my hands on this test. We got in service. My assistant learned how to draw the blood in the office and package it up. It was a woman with a low pretest probability of coronary disease, referred with chest pain. She was very concerned, and her score was 1, which calculated to a likelihood of coronary disease of 8%. So how lucky is that? You know, I was nervous about using the test. This was my first test result. What about my second test? So my second test was in a 69-year-old man that I'd been following for many years who came in with atypical chest pain. 6 years earlier, I had performed a coronary angiogram on him that was, quote, negative. It showed mild or minimal obstructive coronary artery disease. But he clearly had risk factors. He was getting older. He was coming back with chest discomfort that was new for him. His score was 34, which gave a percentage likelihood of coronary disease of 65%. So we referred him for cardiac catheterization, and we found a 70% lesion in his circumflex that was treated with PCI. And after the PCI, he was asymptomatic. Those were my first 2 tests. What about the next 15 tests? Well, I've tended to use this test in people with a low pretest probability as I get to know the test a little bit better and see how it fits into my own practice. And the average likelihood of coronary disease from the scores is between 15 to 20%, with a range of 8% to 35%. I've used the test on about 90% of the patients have been women. I'm starting to change that now. A few of the patients had borderline or mildly positive stress tests prior to the test. And based on these results, I have not referred any of these patients for further testing. The patient that had a score of 35% had a very atypical symptom. They had a low pretest probability, and I was very comfortable in telling that patient that it was very unlikely that they had obstructive coronary disease. So that's what I've done thus far. So far, so good. So after my first 2 tests, I'm mainly using this test in low-risk symptomatic women. I'm also using it mainly in patients with a history of false positive stress tests. So somebody who comes to the office with chest discomfort, may be typical, it may be atypical. In the past, they've had a stress test that was positive, and they've had an angiogram maybe 5 years earlier that's been positive. This is a very common scenario where I practice in Tennessee. I've used it in these patients. I've also used it in obese patients when they're not diabetic. Remember, this test is not yet designed for diabetic patients. There are a few obese patients that don't have diabetes. I think that they are very poor candidates and traditionally perform very poorly with stress testing, given their body habitus and other factors. The worried well, patients that come into the office, they may have risk factors. A typical patient would be somebody who's 55 years old whose father passed away suddenly at age 55 from a presumed myocardial infarction. They're having some funny symptoms. They've got a strong family history. They want to know right now, are their symptoms due to an obstructive lesion? I think this is a very appropriate test in those types of patients. Men that have atypical symptoms. You know, if you think of the Diamond-Forrester plot, people with low and intermediate pretest probability, this test really is an excellent alternative to traditional stress testing. So based on my experience, which has been very positive, I think I've used this in about 35 patients thus far. I'm beginning to use it more and more in the patients that have an intermediate pretest probability of disease. And I've had a very good experience thus far.